A very good morning to everyone. So my name is Dhliwayo. I'm a registrar and who is rotating under Dr. Verenga in the fetal-maternal medicine unit. Today, I'm just going to lead a discussion of a case series which I have titled Complex Pathology Doppler Changes in Trisomy 21, a case series at a tertiary institution in Zimbabwe, 2026. Sorry, just a moment. All right, so I'm just going to start off with giving a very short overview of the Doppler changes of the Dopplers and their changes in pregnancy. So why Doppler studies in pregnancy? These they give non-invasive assessment of the uteroplacental and fetoplacental circulation, and they can help in detecting placental insufficiency before other parameters start to be abnormal, like the biophysical profile or the biometry changes. And this can then help timely delivery in high-risk pregnancies to reduce mortality. So Doppler studies are known to actually help reduce perinatal mortality by approximately 30%. So my slides are not moving again. Sorry, my slides are not moving. Okay, so this is a slide that I borrowed from the FMU Zimbabwe website, which is indicating the timing and roles of Doppler studies. And it's telling us that Doppler studies are useful in screening for conditions such as preeclampsia, fetal growth restriction, aneuploidy, and cardiac defects. For example, uterine artery and ductus venosus Dopplers can be useful in this screening within the first trimester. They are also useful in prenatal diagnosis, for example, for anemia, fetal growth restriction, twin-to-twin transfusion syndromes, twin anemia polycythemia sequence, for example, uterine artery, umbilical artery, midcerebral artery, peak systolic velocity in the second trimester. And lastly, fetal surveillance. And in this case, the umbilical artery, midcerebral artery, ductus venosus, and uterine artery are useful for following up fetuses with growth restriction. This slide is just showing to us to highlight the normal and abnormal uterine artery Dopplers. So I'm just going to go through the normal and abnormal Dopplers for the uterine artery, for the umbilical artery, the midcerebral artery, and lastly, the ductus venosus. So in the first trimester, I'm going to focus on this left picture here. This is normal in the first trimester. We see here the uterine artery Doppler waveform here with systolic here and diastolic down there with a notch, this early diastolic notch, which is quite normal because during that time, the first trimester, they will be still comparatively high resistance within the uteroplacental unit. So the uterine arteries will still be having a high resistance compared to in the late second and third trimester, where we see here that the systolic here is a bit different, slightly different from the diastolic flow here. So the PI, which is the pulsatility index, which is the systolic minus the diastolic over the average of the two, it will actually reduce or decline as pregnancy progresses. So within the late second and third trimesters, this is the normal waveform for the uterine artery Doppler waveform because of an increase or because of a reduction within the resistance in the uteroplacental unit, secondary to the spiral arteries, which would have gone under remodeling to increase perfusion. Now, this one is showing the umbilical artery waveform, normal versus abnormal. So on the left here, this is the normal waveform, whereby the diastolic flow is supposed to be increased, is supposed to increase compared to the abnormal one here, where we see that the diastolic flow is quite much less compared to this normal flow here, because of the same reason, decrease in resistance within the uteroplacental unit. And this one here is another one, which is showing again the umbilical artery Doppler. This is the normal that I've just described before, with the systolic and the diastolic, which shows that the diastolic flow is higher. But if we come on the right here, we see that if we are to check the diastolic flow here, we see that there's reversed flow. So during diastole, instead of blood flowing from the fetus to the placenta, blood is actually flowing in the opposite direction. So this is another abnormal, apart from the reduced diastolic flow that I've shown you earlier on. Just to add a little bit more, because my discussion will talk much more about the umbilical artery Doppler changes. So this is again another illustration which shows that early in pregnancy, for example here, within the first trimester or at 16 weeks, this is expected in terms of the umbilical artery waveform, where we have less diastolic flow here. But as we progresses with pregnancy, we see that there's gradual increase in the diastolic flow, resulting into a decline within the pulsatility index, for example, which I've said is the systolic minus the diastolic over the average. So we see that almost at term, there's quite a difference in terms of the waveform picture compared to what will be happening earlier in pregnancy. So look, going on to the middle cerebral artery. So this is the waveform for the middle cerebral artery. This is the normal one, which I'm pointing here, where we have a high PI across the pregnancy duration. Even in the third trimester, this is the normal waveform, as opposed to the abnormal waveform here, where we have a reduced PI showing that there's increased diastolic flow, if we are to compare with this one. So this is a phenomenon which is highlighted as brain sparing effect for a hypoxic fetus. So when there is hypoxia, the fetus would want to compensate blood supply to the brain, to the heart, to the adrenal glands. So there is decreased resistance within the middle cerebral artery to increase the blood supply to the brain. Lastly, this is the illustration for the ductus venosus, which has got a triphasic waveform. For example, here, this is the systolic, the diastolic, and this is the atrial contraction, the A wave here. So when it's abnormal, for example, on this illustration, we see that we have the systolic, we have the diastolic, and the A wave is a bit deepened here. It's actually a reduced A wave here. So this is just a summary of that I've thought I should just illustrate the normal and the abnormal Doppler waveforms. So what can actually affect the Doppler waveforms, apart from the normal changes that I have described that can happen during pregnancy. There are technical factors, there are physiological factors, and we also have pharmacological factors. For example, maternal administration of steroids can actually result into some umbilical artery Doppler changes. And when it comes to those factors which are pathological, we have the famous uteroplacental insufficiency, and we have a lot of other potential causes: the cardiovascular, the central nervous system, urogenital system, gastrointestinal system, and the skeletal system, which can actually cause changes in Doppler waveforms. So just to summarize this short discussion, because it's going to actually help within my to help me explain the next steps of the discussion. So the Dopplers reflects placental and fetal hemodynamic adaptation. Uterine artery, for instance, it informs us in terms of the status of the placenta, and can be used to screen for abnormal placentation. The umbilical artery Doppler gives us information on the placental function, whether there is placental insufficiency. And the middle cerebral artery Dopplers, they tell us, they give us information on fetal adaptation, like what I've just explained in the previous slides. And the ductus venosus informs us about fetal cardiac status. If there's cardiac strain, for example, or if there's heart failure, fetal heart failure, for example, it can give us that particular information. And when these Doppler studies, or rather, these Doppler studies can be integrated with biophysical profile, CTG, so that they can accurately inform the timing for delivery. For example, the ductus venosus is useful to inform delivery before the gestational age of 32 weeks. So I'm just going to present two cases which we are still managing at Mugabe Fetal Maternal Unit. I'll start with this first case of Miss MM, who is a 34-year-old, and her spouse is 35 years old. She was, when we started to see her, she was in her first pregnancy, and we started seeing her from around 23 weeks of gestation, where she came to us after being referred from a private health facility with the first trimester ultrasound scan that showed that the fetus had increased knuckle translucence and ventriculomegaly of the lateral ventricles. She booked a pregnancy well on time, and her, together with her husband, or rather the spouse, is very supportive. Each time the Mrs. MM would come for antenatal care, the spouse would be there, and within the discussions which we have had with them, you see that there's good support. So she has had several antenatal care contacts, mainly because of the abnormalities that were noted that I'm going to indicate early. And they are newly married, no chronic illnesses from either Mrs. MM or a partner, and both do not drink or smoke. Mrs. MM is employed as a bank teller, and her spouse is a music teacher at a private school. They are still staying with their parents in Waterfalls, as they are newly married, and their monthly income is around 600 to 700 United States dollars. So a torch-spring was ordered, and the result came out negative. Oral glucose tolerance test was done, and the result was normal. So this slide is showing a summary of the ultrasound scan results that we got when they came to this. The couple came to us. There was a singleton, viable intrauterine pregnancy with normal growth from the time she started to see us until recently within this third trimester. We noted that there was severe ventriculomegaly of the lateral ventricles. There was increased knuckle translucence, and the fetus had a ventriculoseptal defect, which measured 3 millimeters. And the Doppler waveforms showed that there was increased PI and absent end diastolic flow in the umbilical artery Doppler, and as well the ductus venosus Doppler was also abnormal. So with these findings, we offered this couple, when they came to us around 23 weeks, we offered them amniocentesis and karyotyping, and they actually managed to pay for this in the private to run the sample, and the results confirmed trisomy 21. So they received a couple of counseling sessions by the counselors which are stationed at the FMU, and an option of termination of pregnancy was included within the counseling, and the parents opted to keep the pregnancy, mainly because of religious reasons. So I'm just going to show you the images which are actually confirming what I've just told you. So this one here is showing that the fetus was viable. This was showing the fetal heart rate, which was 129 beats per minute. It was always normal. I've just picked it at 35 weeks. And here, lack of volume was within normal limits. This was the single depressed pool. Then this one here is showing the knockout translucence. This was done at 24 weeks. And the knockout thickness was 8.1 millimeters here, which was actually elevated. Then coming to this one is showing measurements of the head to indicate fetal growth. On the left here, this was at 24 weeks. On the right here, this was at 35 weeks. And fetal growth, according to the biparietal diameter, was normal. And it was actually normal both at 24 and at 35 weeks. Now here I'm showing you the ventriculomegaly that I've talked of. So this is one of the lateral ventricles, which was measuring 15.8 millimeters, which is severe. It falls in the severe category of ventriculomegaly. On the other side, it was measuring 16.1 millimeters, and as well, this was severe ventriculomegaly. So this picture that I've shown you, this was at 24 weeks when the couple started to come to us. This was now at 35 weeks. There was a slight decline in the size of the ventricles. On the left here, it's showing that it was now 11.7 millimeters, and here 12.8 millimeters. And the couple would seem happy to note that there is some kind of reduction in the size of the ventricles. Now here, this is an ultrasound scan that was done at the level of the heart. On the left side here is showing probably it's not quite, it may not be easily visible to others. It's showing the chambers of the heart. And here the measurement was actually measuring the VSD, the ventricular septal defect, which was measuring 3 millimeters. And this was after adding a color Doppler here, which was showing blood flow through the defect there. In terms of here, I just want to illustrate, this is the abdominal circumference here. This was a transverse section at the level of the abdomen. What I just want to illustrate here is that the fetus was growing well when we are considering the abdominal circumference. The growth was within the expected limits. And I'm going to be discussing about the Doppler findings. So these two pictures here, on the left here, it's actually showing the right uterine artery on the left side here. And as I've shown you earlier on in my first part of the discussion, we see that this is expected because this was what, at 24 weeks. So we expect this kind of a waveform, which has got an increased diastolic flow here compared to what I've described earlier on the abnormal one. And even on the left side, this was indicating that there was good flow of blood both during systolic and as well diastolic. So probably this may tell us that placentation probably was not a problem in this particular pregnancy. Now here I'm showing you the umbilical artery Dopplers for the fetus of Mrs. MM. So if you can remember those normal waveforms here, we see that there's the systolic here is high in comparison with the diastolic. So there's reduced diastolic flow within the umbilical waveform. So if we are to calculate the pulsatility index, for example, which I have said is the systolic minus diastolic over the average of the two, we see that the PI was elevated. This was at 24 weeks. If we come to 35 weeks, there was even absent and diastolic flow here within the umbilical artery. Looking at the midcerebral artery, this was normal. I've said the PI for the midcerebral artery remains elevated within this second, third trimester, and so forth, if the fetus is not compensating. Lastly, on the ductus venosus, this was the waveform on the left side. This was at 24 weeks. On the right side, this was at 35 weeks. And we see that there was a reduced A-wave atrial contraction here. It was reduced just eyeballing. I will show you the nomograms earlier on. But with eyeballing, it shows that there was a reduction within the A-wave there. So during atrial contraction, there was reduction in blood flow within the ductus venosus. So this is now showing us the nomograms here plotted. This one is for the estimated fetal weight. So we see that, of course, the growth, so this one is the 10th percentile, this one is the 90th percentile. So the growth of this fetus initially, or rather, it was in the normal limits, though on the lower borderline here, and at 36 weeks when we last plotted this, we last scanned here and plotted this, it was actually falling within the normal ranges. Coming to the umbilical artery Dopplers, this is the 95th percentile, the 50th percentile. So we see that for all the ultrasound scans that were done, the pulsatility index for the umbilical artery was always above the 95th. It was always elevated. Slightly elevated earlier, and with time, it actually got more elevated, for example, at 35 weeks here. The midcerebral artery was pretty normal, and coming to the ductus venosus, so there was a high PI, as we have seen on the waveform earlier on, late in gestation there. So we walked through the journey with Miss MM and her spouse, and we scheduled for an elective cesarean section at 38 weeks, given the Doppler changes that I've discussed. We thought that this fetus was probably was not capable to face the stress of labor and delivery. And this was conducted, the elective cesarean section was conducted on the 5th of May, just a couple of days ago, which led into a live baby girl with an ABGA of 7 at 1 minute and 8 at 5 minutes, and a birth weight of 2,490. And this is the picture of the fetus here. We can see some of the features of trisomy 21, for example, the loss at ears. I actually covered the eyes, but there were slanted palpebral fissures there. Coming onto this other picture, this is the same fetus. So here we see that there is syndactyly here of the first and second toes there. So this is the case this is the first case. I'm going to go into the second case, or maybe before that. So Miss MM was admitted at Salimugabe. The cesarean section was done at Salimugabe. And we have been reviewing her together with her newborn, and they were doing very well. The pediatricians have discharged the baby, and they planned to see the baby in the postnatal clinics. And the obstetricians have also discharged the mother because she was recovering well, and she will be seen during postnatal care visits. And we are going to continuously follow up on Miss MM and her newborn. So the second case is of Miss RA, who is 35 years old. Her spouse is 37 years old. She is in her fifth pregnancy. She has got 3 children who are alive and well at home, whom she said they reached their milestones normally and they do not have any known illnesses. She had miscarriage in the first trimester. So she was referred to us with an ultrasound scan, which was showing that the fetus had an enlarged kidney at 23 weeks gestation. And she booked her pregnancy quite late at 23 weeks gestation when she subsequently went for the ultrasound scan. She has had 6 antenatal contacts, mainly because of the abnormalities that were noted. And all her 3 previous deliveries were vaginal deliveries, which she reported that there were no complications. So her and her spouse reported that they do not have chronic illnesses, or they do not also take chronic medications. The Miss RA do not take alcohol. She doesn't smoke. She is a housewife, and her partner is a motor mechanic. They stay at their own home in Stone Ridge. Their monthly income is 300 to 400 United States dollars. Miss MM also had a torture screen, which was negative, and the oral glucose tolerance test was also done, and it was negative. To summarize again, the findings of the ultrasound scan that she had in the FMU, we noted a singleton viable pregnancy, intrauterine viable pregnancy, with again normal growth. The fetus had bilateral mild ventriculomegaly in the lateral ventricles and also hydronephrosis. There was polyhydramnios. The heart had a ventricular septal defect, which measured 4.9 millimeters at some point. And the Dopplers showed increased PI and reduced end diastolic flow in the umbilical artery Doppler, as well, pretty similar to the previous case. In this particular case, the parents were offered amniocentesis for karyotype, but they could not afford that because of the finances. And care options included termination of pregnancy. But again, like the previous case, they chose to keep the pregnancy because of religious reasons. I'm just going to rattle through the pictures of the ultrasound scan. Here, as previously, this is showing us that the fetus was viable with a normal fetal heart. This is an ultrasound scan at the level of the fetal heart, showing a heart rate of 139 beats per minute at 29 weeks. Then this one is showing the single deepest pool here, which is measuring 11.9 centimeters, which is polyhydramnios. It's actually above 8 centimeters. Then here, this is showing the prenasal thickness, which is 11.1 millimeters, which is elevated. And coming to this slide here is showing, I'm trying to indicate how the fetus was growing in utero. With regards to the biparietal diameter here, the growth was on the almost on the 98th percentile, and coming to the femur length here, it was slightly reduced on the 8th percentile here when we consider femur length. But I'm just going to show you later on the nomograms for the estimated fetal weight. Here I'm showing you, this is the fetal head, and this is part of the lateral ventricle, which was measuring 11.2 millimeters. That is elevated. It's ventriculomegaly on one side. Here is still the fetal head showing the other ventricle, which is measuring about 11 millimeters, which is also indicating ventriculomegaly. Well, I'm still showing the fetal head here. This is the fetal head. And this one is the previous slide that I have discussed. This was at 29 weeks. Now this was at 33 weeks. So the repeat measurements for the lateral ventricles, it was about 10.6 millimeters on one side and 10.3 millimeters on the other side. So probably a slight reduction. I'm not too sure if this would be a significant reduction compared to the previous measurements at 29 weeks. This is on the left side here. This is a transverse section at the level of the heart, which is showing us the heart chambers there, but it's also showing us a defect here, a ventricular septal defect, which was measuring 4.9 millimeters. And this was after adding color Doppler. It's showing that blood is actually flowing through the defect. This is a transverse section at the abdominal level, which is showing that, so this is one side, this is the other side. So it's actually at the level of at the renal level here. We see that one of the ureters at the proximal end is measuring about 27 millimeters here, and the other one about 10 millimeters. So there's actually hydronephrosis. This is so this was the transverse. Now this is the other section. The sagittal section is also showing the same picture, that there was hydronephrosis. Coming to the abdominal circumference, here this is the level of the abdomen, measuring the abdominal growth, and the growth was within expected limits. It was 88% when we consider this, the growth of this abdomen versus the gestational age. I'm going to the Dopplers now. So here I'm showing the uterine artery Dopplers. This is the right uterine artery Doppler, which it's a bit, the picture, it's inverted here. It's different from what I've been showing earlier on. But this is, it's actually showing that these were actually the Dopplers for the right and the left uterine arteries were actually normal. Coming to the umbilical artery Dopplers. So again, we see a similar picture. This was a 26 weeks gestation. There was a reduced diastolic flow here, is going to be confirmed by the nomograms. So the PI, this minus this over the average, was elevated at 26 weeks. Coming to 33 weeks, this was the end diastolic flow was almost absent here within the umbilical artery Dopplers. Mid-cerebral artery Doppler, it was actually normal because we see that we do have a high PI at both at 26 weeks and as well at 33 weeks on this other side. And lastly, the ductus venosus waveforms here, they were normal for Miss RA. The ductus waveforms both at 29 weeks and at 33 weeks gestation, they showed normal waveforms. Now these are the nomograms. This one is showing the estimated fetal weight, which was actually moving at the 50th percentile here on the midpoint here, showing that the fetus was actually growing well if we are to look at the fetal weight. And coming to the umbilical artery Doppler for PI, for pulsatility index, we see that the PI was elevated from the start, from the time we started seeing Miss RA. And it actually kept on going high. We actually saw here yesterday at 36 weeks plus 2 days it was even more elevated. So this is the MCA, which was slightly lower during all the visits that she made to us. And this one here is showing the ductus venosus, which was normal if we are to look, for example, at 33 weeks when we last scanned here. So yesterday when she came, we repeated again the umbilical. We were following her up on the abnormal umbilical artery Dopplers, and we see here that there is now a reversed end diastolic flow here. Like what I've shown in my earlier talk, the end diastolic flow is now on the opposite side. So during diastole, blood was probably flowing in the opposite direction within the umbilical artery there. So with this, we then ordered, because she was 36 weeks, 2 days yesterday, and she was also complaining of a bit of lower abdominal pain and backache. So we then ordered an elective cesarean section, which I'm still just to check. Yesterday she was not yet done. I'm going to be checking on her this morning the outcomes of that particular cesarean section. So this is the description, a short description of the two cases that we managed, which both the first one had confirmed trisomy 21 on amniocentesis with some kind of normal growth and abnormal Dopplers, especially the umbilical artery Doppler waveform. And here on the second case, a similar picture again. But on the second case, the Dopplers actually, the umbilical artery Dopplers worsened such that yesterday we ended up ordering preterm delivery, late preterm delivery. So I'm going straight into the discussion. As I've just described, one of the major finding here is that there were abnormal Dopplers in both cases of trisomy 21, and this was mainly the umbilical artery Dopplers, with probably that information that we have so far, there was no evidence of fetal growth restriction. So probably what could actually explain this is what I'm just going to be discussing on in the next few coming slides. So I've looked at a couple of studies to say we expect that if these Dopplers are getting normal, like what we have seen, in most of the instances, there would be some pathology somewhere, is it placental insufficiency pathology, which is actually giving an abnormal umbilical artery Doppler, like what we've discussed earlier on. However, indirectly, we would have expected to see abnormal fetal growth. But in both cases, we noted that there was normal fetal growth. So there are some articles which have looked at this, and I'm just going to be talking about them. The other finding that we noted in this particular two cases is that both of them were the suspicion for trisomy 21 were found when the mothers had gone for routine ultrasound scanning without any symptoms. So it gives it underscores more importance of routine ultrasound scanning, so that these abnormalities such as these can be picked early, and the parents can be offered a holistic array of options so that they can choose and they can actually have timely management and timely appropriate management. So this is an article that I found where the researchers or rather it's titled Impact of Fetal Trisomy 21 on Umbilical Artery Doppler Indices. And their objective was to demonstrate Doppler patterns across gestation in fetuses with trisomy 21, compare with euploid fetuses, and investigate their association with pregnancy outcome. It was a retrospective cohort study covering the period 2012 to 2019, where they looked at 86 fetuses with trisomy 21 against 130 euploid fetuses within at a tertiary hospital in the United States. So what were their outcomes? They noted that approximately 56% of the trisomy 21 fetuses had at least one Doppler value, which was abnormal, which was elevated above the 95th percentile. And at birth, 9.3% of the trisomy 21 fetuses were small for gestation. So it means the other almost 90% of fetuses which had abnormal Doppler waveforms had appropriate or even increased, had appropriate growth, or their growth probably were above expected. So after stratification, the researchers stratified in other ways. They actually extracted data for the fetuses who had trisomy 21 and they had normal growth, for example. And they noted that the umbilical artery Doppler indices remained higher for trisomy 21 compared to the euploid ones. So for those who had normal growth, looking at both arms, they noted that the umbilical Doppler indices were high, even if they had removed those who had small for gestation, the 9.3% who had small small for gestational age recordings. And two of the fetuses had persistently elevated Dopplers above the 95th percentile. So some of the fetuses actually improved their Dopplers. They actually normalized. So they then went on to say, given this, probably could there be some form of subtle placental insufficiency such that it could not be picked using Dopplers, for example, using the umbilical artery Doppler. So they followed up on the histology for the placenta for these fetuses. And they noted that in more than 90% of the fetuses who had abnormal uterine artery Dopplers, histology was normal. It did not show features of abnormal placental growth within for those fetuses who had trisomy 21, and only less than 10% had abnormalities on the placenta from histology. They also noted that 3 of the trisomy 21 fetuses ended up in fetal demise because the Dopplers were actually worsening and they ended up demising. So the conclusions, according to this particular article, was that reference intervals based on euploid fetuses may therefore not be appropriate for antenatal surveillance of fetuses with trisomy 21. And they were suggesting that probably these fetuses, they need their own nomograms. That was their conclusion. So they then went on to try and compare the nomogram for the euploid and those for the fetuses who had trisomy 21. So on the left here, this is for the umbilical artery systolic over diastolic ratio, and this one is for the resistive index here. So the dotted lines are for trisomy 21 cases, and the continuous lines are for the euploid. So the various colors are showing the 5th, the 25th, the 50th, 75th, and 95th percentile. So if we are to take these lines as a set, for example, I'm looking at the continuous ones here, which are showing the various percentiles up to the highest percentile here, the 95th percentile. We see that the SD ratio here for the euploid ones is less compared to if we are to look at these ones with the trisomy 21. The nomogram is generally showing that they had elevated SD ratios here, which actually started to increase after around 36, after around 34 weeks of gestation. The same goes for the resistive index. We see just a similar picture to say the nomogram for the trisomy 21 are showing higher values compared to the euploid ones. And this is for the pulsatility index, almost the same picture. We see that after about 34 weeks, it starts actually going up, which is actually resonating with our finding in the two cases, that after within the late third trimester, the pulsatility index actually started to rapidly worsen. And in one of the fetuses, we ended up ordering emergency cesarean section. A different article, so that was a retrospective that I've looked at. Unfortunately, I could not see quite a lot of other articles or even better articles which had better study designs. So I could only find retrospective and case studies. So for this one, the researchers titled Increased Umbilical Artery Pulsatility Index in Third Trimester Fetuses with Trisomy 21. And their objective was to examine the umbilical artery Doppler flow patterns in the late third trimester fetuses with trisomy 21. It was a retrospective study again, and they evaluated fetuses with trisomy 21 after 33 weeks of gestation. So it was a bit late in the third trimester. And they looked at 42 fetuses who met this criteria. So their findings was that in more than half of the fetuses here, both PI measurements were above the 95th percentile. And the umbilical artery PI was not dependent on the abdominal circumference or any other examined maternal or pregnancy characteristics. For example, the head circumference, the femur length, which would actually tell us if the fetus is growing normally. And their conclusion was that in half of the third trimester fetuses with trisomy 21, the resistance in the umbilical artery was increased even in the absence of placental insufficiency. This is another article which aimed to investigate the relationship between ductus venosus and the top three fetal aneuploidies, trisomy 21, 18, and 13. It was a meta-analysis which was published in 2019, and it looked at 9 studies for trisomy 21, and the fetuses for trisomy 21 were about 31,053. So what were their findings? They noted that here on the table, this is for trisomy 21, ductus venosus, trisomy 21, with an odds ratio of 3.44, and this is the confidence interval and the p-value. So the explanation here is fetuses who had trisomy 21 were at least 3.4 times more likely to have an abnormal ductus venosus compared to the fetuses who did not have trisomy 21. So there was some kind of association. And 63% of those with trisomy 21 had abnormal ductus venosus. So this is actually supporting integration of the ductus venosus as a biomarker in the first trimester as part of a combined test to increase prediction of aneuploid. Another article here, which was titled Outcome After Prenatal Diagnosis of Trisomy 13, 18, 21 in Fetuses with Congenital Heart Disease. So here I picked up this article because I then wanted to look at the possible outcomes, which would be very important when we are counseling the parents for the newborn in the first case, and this one who probably has been delivered. So their objective was to assess stillbirth and neonatal mortality rates for pregnancies complicated by congenital heart disease and trisomy 13, 18, and 21. It was a retrospective cohort study from 2000 to 2020, and they looked at 150 fetuses who had trisomy 21 at one of a tertiary institution in Austria. So their findings were that 61% families, they opted after they were cancelled that your fetus has got trisomy 21, they opted for termination of pregnancy, leaving out about 39%. And of this 39%, 16 of them had intrauterine demise or intrapartum death. Probably the researchers did not actually highlight the causes of those deaths. So probably because of the worsening Dopplers or other abnormalities. The live birth rate was at approximately 88% for trisomy 21, and early neonatal death was observed in 9. That was almost 20% of infants who had trisomy 21. 31 of those fetuses who were born alive survived the first year of life. So that was about 86% of those who were delivered as live births. So they survived at least the first year of life. So their conclusion was that this data may be helpful for counseling affected parents when the decision to terminate or to continue pregnancy should be considered, as in our 2 cases. I'm going to be looking at the last article here that was presented and published during the 21st World Congress in Fetal Medicine, with the title called "Should Patients Carrying Fetuses with Known or Likely Trisomy 21 Be Managed with Dopplers?" So here I'm trying to look at what could be the acceptable follow-up pattern for these fetuses, given the findings that I have discussed so far. How can they be then followed up, even if they have got normal Dopplers on the first visit or normal findings on the first visit? So their objective was to determine whether fetuses with trisomy 21 develop growth and fetal Doppler abnormalities during pregnancy, a retrospective cohort from 2018 to 2023. And they looked at 67 fetuses at a tertiary hospital in the United States of America. And their results showed that trisomy 21 fetuses had an increased risk of fetal growth restriction. This was sounding a bit different from the other articles and from our 2 cases, with the average or estimated fetal weight remaining just above the 5th percentile, beginning at 28 weeks and continued to term. So the 50th percentile of the umbilical artery Doppler appears to increase slightly through the course of the pregnancy and becomes abnormal after 32 weeks. This was their finding. After 32 weeks, that's when they noted that it was getting more abnormal. The median MCA, PI, middle cerebral artery pulsatility index, decreases after 28 weeks and approaches the 5th percentile after 36 weeks. So probably here it's telling us slightly a bit different story from ours. We noted that these Dopplers were abnormal earlier on around mid-second trimester. So approximately 20 to 30% of the fetuses in this particular study of normally grown fetuses with trisomy 21 had abnormal Doppler values at some point during pregnancy. And what was their conclusion? Fetuses with trisomy 21 developed Doppler abnormalities suggestive of late growth restriction, because they noted that the estimated fetal weight was on the lower side. And their observations, they said, may explain why some fetuses with trisomy 21 experience intrauterine fetal demise. And fetuses with known or suspected, our first case had a known, the second case had suspected trisomy 21, should be monitored with uterine artery and middle cerebral artery Dopplers, especially from 32 weeks of gestation, even if they did not have abnormal Dopplers. So I was then trying to find out if there are guidelines which are kind of guiding how these fetuses can be managed. And it was a bit difficult for me to find the guidelines which were specifically talking about follow-up using ultrasound scan, how these fetuses with trisomy 21 are supposed to be followed up. So this is a guideline from one of the hospitals which then it said ultrasound scans at 28 to 32 and 36 to 37 weeks gestation must be done to assess fetal growth and Doppler blood flows for fetuses with trisomy 21. So I'm not too sure if that can actually fit some of the cases. For example, the previous article, which said after 32 weeks, that's when they noted that they were abnormal Dopplers. And they also gave guidance that induction of labor is supposed to be done for the fetuses with trisomy 21 from 39 weeks of gestation. So the conclusion from this case series is that fetuses with trisomy 21 often have abnormal umbilical artery Dopplers that may actually worsen, such as in our second case. Hence, close fetal Doppler follow-up is important, especially for those who choose to continue with pregnancy. And what are the possible recommendations? Probably there's need to specify how these fetuses with trisomy 21 must be followed up with ultrasound scan despite having a normal growth and normal Dopplers, such that it can be followed. And secondly, I recommend that it may be important for us to generate local data in terms of the natural the history of these fetuses at our FMU unit, such that we can keep a database of fetuses complicated by trisomy 21 and follow them up to describe their natural history, such that we can inform how to follow them up during pregnancy, during delivery, and post-delivery. Because as we have seen, most of the articles that I've cited, almost all of them, their approach was a retrospective kind of an approach. So that would be giving a weaker kind of data compared to a prospective one that can be obtained if we follow this particular strategy. So this brings me to the end of my discussion. Thank you.
Thank you so much, Dr. Dhliwayo. Our time has run out, but I think let's have 5 minutes for questions. Well done, great presentation there, and great work you have done to try and search the literature to explain what is going on. Well done, well done. Any questions you may want to pose? Any questions, guys?
Maybe not a question. This is Dr. Louisa Mdawarima. I'm a developmental pediatrician, but more of a comment. I think one of the other things that we need to be doing during this antenatal period, if we're picking up some of these aneuploidies, is a thorough counseling and explanation to our patients of what the implications of the long-term care of these infants is likely to be like. As Dr. Dhliwayo correctly pointed out, you have a higher risk of intrauterine as well as perinatal complications for these children. But even in the neonatal period, there's still a lot of need for multidisciplinary input because they can have any number of complications, including gastrointestinal, hematologic, endocrine, cardiac complications, all of which are going to need input from the relevant specialists. And parents need to be prepared for this. As developmental pediatricians, we like children who have Down syndrome on a purely personality front. They tend to have an uneven developmental profile where, their personal and social development is far ahead of the other aspects of their development, including gross motor and fine motor, as well as sometimes even language skills, although they tend to have a relative catch up in, all of those developmental areas and are able to function later on as adults. But you can imagine that they will have long-term care requirements. They are more likely to develop complications like leukemias. They're more likely to have early onset dementia. And, in the context where you have older parents who are looking after these individuals, that can be quite taxing for families. I think the other issue that we also need to think about is in the first case, it seems like this was a relatively young mother who was a first-time parent. And we need to think about the, other patterns of inheritance of this, of the trisomy 21, where we need to be thinking about things like um, balanced translocations in the parents, because we need to be able to counsel them as they come to ask about whether or not it's safe for them to have another child. I think fertility issues with regards to how do I move on from here are some of the most frequent questions that we are asked as developmental pediatricians. And we need to be able to have information to inform whether we encourage these young people to proceed and have their families or not. I'm going to stop here. Thank you.
Thank you so much, Dr. Mdawarima. I want to say thank you for joining us and for giving your expert opinion. Dr. Mdawarima, I think you have raised a very important issue, which we take seriously, the issue of counseling. I think we now recognize from what you have just said that our counseling package is missing you in particular, or your team in particular, especially for couples who go on to, actually for all couples with aneuploidy babies and probably genetic syndromes. I think or babies who are going to face developmental issues, I think that covers including the ventriculomegalies or brain abnormalities. So we will probably be referring some of the parents to you guys for prenatal counseling, for further prenatal counseling, because I think you know the journey that these babies go through more than we do. So we will certainly be referring some of the babies, the parents, to you guys for further counseling, like probably these two couples presented here. We should have referred them to you so that they get further counseling, so that they prepare for this long journey, even considering that they were both committed to the pregnancy despite the diagnosis. Then the first couple you highlighted, when you ran the karyotype, the lab confirmed that they had the non-disjunction type of trisomy 21. So for these ones, it was confirmed by the laboratory that the non-disjunction type. But for the second couple, we don't know since they didn't afford the test. But what you have highlighted there is very important for us now and in the future as we continue to see these parents. Yeah, but that was very important. Thank you so much for bringing that to us. Dr. Dhliwayo, the question to ask you, the other, you told us about the placenta, the American study. The placentas were normal in about 90-something% of the cases. What did they find in the other placentas, just for interest sake? Because from all the studies that you have managed to find, we did not get the histological explanation as to why the Dopplers get so deranged for these babies. But otherwise, these are babies who are probably happy with this kind of deranged Dopplers. A totally different picture we see in vascular mediated placenta insufficiency. I think you guys agree with me that all these mothers were happy with the fetal movements until we take out the babies. Babies were jovial in there, but the Dopplers are deranged, which is totally opposite to what we see in vascular mediated placenta insufficiency, the preeclampsias, where if you have an absent in the diastolic flow, the babies are not moving at all. The babies are very sad with hypoxia and so forth. So what did they find in these placentas?
Okay, thank you very much for the question, for the comment and question, Dr. Verenga. So they said the pathologists described some features of placental insufficiency, and some of the features which they described in the narrative included villus hypoplasia villus hypoplasia, and they also described some presence of infarcts, which probably would point towards coagulative necrosis of the villi, of the chorionic villus as well, and deposition of perivillus fibrin. So this is some of the description which they gave with regards to the abnormal placentas, and they summarized to say the placentas showed features of insufficiency.
Thank you. Thank you. Did you find any cases that are more or similar to ours where the Dopplers are so badly deranged to the extent of an absent EDF, or most of the cases were just elevated PIs?
So most of the cases that I found were that of elevated PIs, but one of the articles that I have cited here, they said, unfortunately, they did not describe the follow-up, the Doppler follow-up to try and explain what then resulted, how these three fetuses ended up dying, which had abnormal Dopplers. So I was suspecting probably it was because the Dopplers had worsened, but this was not given. This is an extrapolation. It was not given within the description. So in this particular article that I'm highlighting here, they said 3 of the fetuses with the trisomy 21 ended up in fetal demise, but unfortunately they did not describe the patterns that resulted in the fetal demise. But I think it's a good question. I'll just keep on looking for literature to see and to try and answer the question that you have posed to me. Thank you.
Thank you. Thank you so much. Do you have any questions you want to ask before we close it? But our family therapists, would you want to share your experience of talking to them, to these two couples? What were the issues that emanated from your interaction with them? Are they in the meeting? I think I can see Fende is in the meeting. Do you want to just share with us what were the issues when you guys were counseling these two couples? That were there any similar themes, similar patterns you noted? Because some couples will go for termination. I think we've done a number of termination for these conditions, but these particular two couples, they chose to keep. Any imaging things you noted you want to educate us on?
Yeah, thank you so much. Good morning, everyone, once again. All right, the themes that we have been discussing with these patients, those two ones, we mainly focused on palliative care, post-birth, and prior to birth. So their religions were the factors which contributed to them to keep the babies, because they said we don't have the power to rule out death. We need to keep these babies. They are a gift from God. Then we supported that. In mental health, we don't have to give them information, but we actually support what they want. So we further on discussed about how they are going to be taking care, and we are still in the process to dig more about their relations, the family, society, or how would they view the situation. But the other one said their family is in support of keeping the baby. Also, they have the support from their church, the pastors and other church members who are also contributing to the upkeep of the baby. There was something which was put on the table, like finances for hospital bills and transport as well, for any reviews and any medical expenses. So that was all. Thank you.
Thank you very much. Thank you. So for future presenters, I think always interact with the family therapists on this kind of cases, so that as you present, you bring that to light, because the management is never just by the clinical team. It's a multidisciplinary team effort, as Dr. Dorma mentioned to us there. So yeah. Dr. Dorma, do you want to say something?
Thank you, Dr. Verenga. I think a lot of the time, what we highlight is, the antenatal and the perinatal complications. And a lot of families don't understand that there are some long-term issues that they are going to have to deal with. And very often, some of the issues come up later, and issues of neglect and those other things that actually technically also go against the religious beliefs of the family become apparent later on. We have a lot of issues of families failing to deal with puberty and pubertal changes with their young, daughters and sons who have trisomy 21, things like menstrual management, things like, how to handle, relationships and romance, how to handle chronic illnesses. So, for example, when we start having that early dementia side of things, it can be very, very difficult for families. And very often these financial commitments that you get from the church or pastors, etc., are normally only geared towards the short term. So families, I absolutely agree. Families do have that freedom and should make the right choice for them as families, but they need to be fully, fully informed of the long-term implications of what they are committing to.
Yeah, I think that's a very important issue you have raised, Dr. Mdawarima. Mr. Pende, yes, you may come in. Probably be the last one, then we can close.
All right. We once help the patient in researching more about the long-term implications, and they are now well versed in it. They even went on to research more on how to take care of the baby in the long run to their adulthood, and they even opted to collaboration in terms of forming an organization which will stand for their babies, trisomy 21. So that was the thing we mentioned, and we discussed, we counseled them on that, and they're even digging more into how to take care of their babies till the old age.
Okay, great. Yeah, I think thank you. Thank you, everyone. I think we've learned a lot during this session, and I think we need to increase our collaboration with Dr. Mdawarima and the team, the developmental specialists, when it comes to all these defects that affect our babies are going to develop later on in life, so that we can enrich the information that clients have before they make the decision on the pregnancy. So it's something that we now need to integrate into our care pathway, so that we offer holistic care. To be honest, for me, this gives me a lot of nightmares just think what happens to this all these couples with all the problems highlighted here. So thank you so much, guys, and have a great day. Well done, Dr. Dhliwayo. Great presentation. Bye-bye.